Good afternoon. I know it's cold, but a little better than that. Good afternoon. Hello. Justin, I know there's some people in the room that are very, very shy, so we'll have to get over that. I appreciate everyone coming to this great event on climate change. I'm kidding. The next third rail issue, healthcare. But it is an important issue. A couple of housekeeping things right out of the gate. We have index cards that were left on your chairs with hopefully something to write down a note or question with. We're going to take questions on your note cards, and Patty Strock, who's our Director of Policy Research, is going to collect those and help hopefully move along some of the process so we can get as many questions in as possible. So if you have a question as we go through the course of the day, please feel free to write them on the card. You don't have to put your name. It can be anonymous if they're tough questions. But please, throughout the day, as the keynote's happening or as the presentations are happening, write a question down and get it to somebody in staff. You'll see them with a lapel, Michelle, and others, and they'll handle that. First of all, I'd like to thank you all for coming, and I'd like to thank the staff at the Institute here for pulling this together today. Let's give them a big round of applause for pulling together such a great event. We have been talking about a lot of issues in the news, and this is one of the key issues that we are all concerned with. How do you address the policy issues of access to high quality and affordable health care? It remains a priority for much of the nation, including in New York State. And of course, the problems vary overall between quality, affordability, access from state to state, and as states grapple, quite frankly, with the various changes at the federal level, which seem to be happening quickly and with not much stability. So in the shadow of the federal actions, how do states get in the game and solve some of their own issues? One such solution, and we've been holding a series on this, we had Bea Grouse, the head of the Health Association, here a couple of weeks ago, who provided her vision of healthcare, and Courtney is representing them today, which is great. Is a really wonderful piece that we put out in October, not because we put it out, because the piece was actually wonderful, by John Kalin, who is a visiting fellow at the Rockefeller Institute and also a senior executive at Centene, and his co-author, Catherine Hempstead, who's a senior policy advisor at the Robert Wood Johnson Foundation, of their concept of expanding healthcare through Medicaid for more. And we're going to hear about that momentarily. And I think it really lays out a lot of important principles of how states can expand their health care access and also the quality and affordability potential of those issues. I'm not going to read through their bios, but they have a really great, distinguished career. It's in the programs that we left on your table, on your chairs, but both have deep research experience as well as governmental experience, which is really important in addressing some of these issues. After we hear from John and Kathy, we're going to turn it over to a panel of distinguished experts on the topic, and we'll have a lively debate. None of them on the panel are shy, and hopefully we'll begin to tease out some of these issues, especially what's going on in New York. What are the key issues in New York? What are some of the issues that we're facing in New York that are different than other states? How are they similar? What do we do with the federal action or inaction? So I'm really delighted to have John and Kathy here today, and I'd like to turn over right now to John Kalin and Catherine for their keynote address on Medicaid for More.
Good afternoon, everybody, and Jim, thank you for that great introduction. I want to start out by also doing some thank yous. First, Kathy, thank you for co-authoring this. Kathy and I have got to know each other during a couple years ago when there were some real challenges with the so-called health exchanges, which I'm going to talk briefly about in a minute. And then I had the pleasure to work with the Rockefeller Institute for about the last year and a half, where I've been a visiting fellow with Jim and Tom and others. Patty has been a great partner, and it's just been a great opportunity for me to explore some issues that are, very relevant and require a bit of a deeper dive than you can do sort of in a day-to-day work environment. And then lastly, I want to thank the panelists panelists who I really just met on a prep call, and what a fabulous group. I took a page of notes on Thursday afternoon as we did some preparing, so I'm going to really be excited to learn more from them as the afternoon goes on as well. So let me just start out with what kind of my vision of this paper was, and then we'll do a bit of a level setting, a little bit of a definition of terms, so we all know what we're talking about here when we talk about buy-ins, public options, Medicare for all, that kind of thing. For me, this journey really started about 2 years ago, where if we go back to 2017 and we think about what was happening in the so-called Obamacare markets, the exchanges, you didn't have this as much in New York, but in a lot of states there were some enormous threats to the viability of the exchanges. What we were seeing was a House lawsuit on a key financing provision of the ACA, and that created a lot of destabilizing aspects. We saw from 2014 to 2016, a lot of the insurers on the new exchanges were actually losing money, and a lot of them pulled out. That led to a situation where we had some parts of the country, and again, this wasn't the case in New York, but it was certainly the case in some of the Midwest states and southern states, where you had one plan offering ACA coverage, and there was threats of having no plans in some of the counties, the so-called bear counties. And so out of that, in Nevada, kind of out of the blue, actually, in the summer of 2017, a legislation was proposed by Representative Sprinkle in the legislature out there that proposed a Medicaid buy-in. And the idea was that there were going to be, the potential was there were going to be some counties where there would have been no ACA option. Nobody would have access through the ACA. And so that sort of struck, a light bulb went off for me, and it raised a lot of questions, that some of which are in the paper, like, what problem are we trying to solve with this? Who would be eligible for this? What's the impact on the existing marketplaces? There's just a series of questions which we tease out in the paper, and we'll kind of get into a little bit in the discussion here. But the interesting thing about that legislation is it was like 2 or 3 pages, and it was going to really kick a lot of this to the executive branch, the governor there, to kind of figure those things out. The bill was ultimately vetoed. Other plans came in, and the problem kind of got resolved. But if we fast forward now, year and a half later, we're seeing these Medicaid buy-in ideas and these public options ideas sort of just exploding in the public policy space now. And I thought it would be useful to just take a quick look at and try to do some level setting and defining terms here with these different kinds of alternatives. So if we think about sort of along a continuum, and we think about sort of the most incremental ways to expand coverage, obviously we have under the ACA the Medicaid expansion. A lot of states have opted into that. We still have a bunch of states that have not, although of interest. Now that the elections are over, we're seeing a lot of discussion on the part of some big states about expanding Medicaid. We're seeing voter referendums to expand Medicaid, and there's a lot going on. Even Georgia, in their budget, they've put in money to hire a consultant to look at the possibility of expanding Medicaid. So that's sort of one sort of incremental, sort of the smallest step. Then as we start to move to the right, that's where we get into this concept of a so-called public option. And we've seen different, even before this round of presidential proposals, we've seen different ideas emanating from the Congress, this Choose Medicare Act, and other kinds of buy-ins for Medicare where individuals, say, under 65 but over 50 might be able to buy into that program. And then the whole series of proposals at the state level to permit these buy-in programs. And we've got a great panelist, Dan, who's going to do a deeper dive on what's happening in New Mexico and Connecticut and Washington State, where lots of programs are being discussed. And then as we move across, and this is where I think it's going to get really interesting with the presidential election and the various proposals, as we move across, we see different ideas that are fundamentally directed at moving more people into public programs via the Medicare program, and over time, potentially replacing some of the private insurance with a Medicare single-payer kind of arrangement. And the Center for American Progress had a proposal that came out about 1.5 years ago that looked to move this fairly slowly, while some of the other proposals that we're looking at now that coming out of the Congress are looking to do things more quickly, potentially eliminating or drastically reducing the role of private insurance. And what's really important about that concept is most of us in this room, I think, and more than 150 million Americans get their coverage through private insurance. So the idea of moving to a much more publicly financed program on a public platform certainly is it's profound in terms of its implications, of which we tried to raise in the paper. You know, the provider rates, the payment rates, who would be eligible, the impact on the delivery system, and so on and so forth. So I'm going to stop there to kind of get us warmed up. I'm going to turn it over to Kathy. She's going to do a little bit of further discussion, and then we're going to begin our Q&A with the panelists. So, and Jim, thank you again very much for doing this.
Thanks, John. And good afternoon, everybody. And I also will thank you, John, as my co-author. It was a great opportunity to work together on that paper. And boy, it has a lot changed since then. I think the things that we thought were really remarkable then seem almost like minor compared to some of the things that have been proposed and discussed since then. So I'm just going to sort of pull out to 30,000 feet or, you know, whatever, and provide just a few framing ideas that I think are kind of interesting when we think about all these proposals. It seems to me that right now we're experiencing a period in healthcare and health reform where there's a lot of creativity, but there's also a lot of dissatisfaction. And I think we can see evidence of both sort of all around. I mean, we see a lot of evidence of creativity by state governments with the way they're approaching things like waivers and reinsurance, and I think Dan's going to get into some of the different public plan things states are doing. We see a lot of creativity more on maybe delivery system reform from the federal government, and then we see lots of innovation in the private sector. And we see a lot of really exciting public-private collaboration around healthcare. But at the same time, you know, there's also a lot of dissatisfaction, and we see a lot of evidence about, you know, profound dissatisfaction on the part of consumers with healthcare and their access to healthcare and what they're spending for healthcare. So, you know, we see that in the really rancorous politics around the ACA and the healthcare voter in the midterms. We see, I think, really high-impact investigative journalism that's taken shots at different stakeholders in the healthcare industry and found a really, you know, warm reception. And, you know, I think that we also see, you know, a lot of activism lately around things that pertain to affordability and access to healthcare. You know, we see movements against prescription drug prices and pharma, and we also are seeing expanded calls for increased coverage, increased access, and increased affordability. And you know, some of those calls are for, as John mentioned, things that would really disrupt our current paradigm and create sort of a different system altogether. And I think you can sort of trace both the creativity and the dissatisfaction back to the process of the ACA, where I think a lot of that creativity is kind of a creative incrementalism that really builds on the structure and the opportunities that the ACA created. But at the same time, I think there were people that felt the ACA didn't go far enough. And I think there are people since then who have maybe felt disappointed with certain aspects of how things have turned out, like the affordability problem for unsubsidized folks, or for people who look at the, you know, the politics around work requirements and the sort of, you know, the incomplete expansion of Medicaid and wonder whether Medicaid is going to be the right vehicle for low-income people. So I think we kind of see that dissatisfaction as well. So I think we see with this collection of proposals, which I kind of call public plan options, as a shorthand, I think we see both that creative incrementalism, and then we also see that dissatisfaction and desire to do something sort of more disruptive at play. And I think we're going to talk about both the state and the national approaches. And we, John and I started out talking about a set of state approaches that I think you could largely view as kind of incremental, because they, even though they would have significant consequences for stakeholders, they were largely targeted at the individual market. There are a handful, and we're sitting in a state that has one of the more kind of disruptive state proposals. So there are some single-payer proposals, and the states are talks about them sort of in various stages. But the state activities, by and large, have been a little bit more incremental. The national proposals, which have kind of really blossomed sort of since we wrote this paper and have occupied a lot more people's attention, I think are less incremental as a rule, but they fall along a spectrum. And I feel like one way I like to think about these public plan proposals is the way they sort of work is they either are allowing people to buy a product that already exists, although that often requires some modifications, or they are sort of repricing some product that basically already exists using the leverage of the public sector, or they're building a completely new product. And I think Dan's going to talk about how we see all three kinds of things in state. And I think the federal proposals also, there's examples of each. So there's the Medicare at 50, which is sort of a buy-in, although it requires some modifications to Medicare. And then there's a big handful of proposals that are basically sort of repricing a QHP or altering a QHP and using public sector leverage to apply, Medicare rates most of the time, or Medicare pricing leverage to a QHP. So some people refer to that as sort of a public option on steroids. And from there, I think you can see a bridge to the state proposals, where sometimes the origin story of some of those national proposals are problems that are rooted in the individual market, like Bexar counties, as John, and some of the other issues. But the vision is quite a bit more expansive. And then at the end of the spectrum, as John referred to, I think we see the sort of the build proposals, which are really, disrupting the current paradigm and, have significant consequences for other coverage segments. And I think it will be sort of important to talk about them all. And so I think you can see sort of creative incrementalism and, like dissatisfaction kind of represented in all these proposals. And I just think, things to think about as we talk about them, and I'm looking forward to the conversation today, is, what do these different proposals accomplish in terms of coverage? Who do they expand eligibility to? Do they achieve universal coverage? What are the implications for affordability, both for individuals and for society? How do providers get paid? How do we pay for prescription drugs? What are the implications for federalism, for sort of state-federal power dynamics, which I think is important for some of them? And, what are the implications for other coverage segments? And I just would close by saying, it's interesting. If anyone read the New York Times yesterday, you saw the big article on sort of the politics of Medicare for All, and how it's creating kind of a, kerfuffle within the Democratic Party as people try to figure out how to respond. And there's, a stakeholder coalition mounting. And I think in our society, we tend to get sort of more interested in the meta issues sometimes. So the story of the issue becomes more interesting and easier to follow than the actual details of the plans themselves, which I think are, are very consequential, but maybe not as sexy. But I think the sort of the meta narrative is taking hold, and there are lots of things to think about, especially in light of the, the upcoming presidential election, where people are trying to array themselves around the issue in various ways. And it's anybody's guess what's going to be the ascendant idea that appeals to the, to the majority of people and sort of goes forward. But I think we have had episodes in our past where there's been an elevated level of consumer dissatisfaction about the cost of something, or sometimes it's insurance, sometimes it's utilities, and sort of holding policymakers accountable to a certain level. And we usually do see some changes as a result. So it will be interesting to see what happens in this case. And on that note, I will step down and we can begin our panel.
Let's give John and Kathy a big round of applause. I urge you, if you have the report in front of you, download it as well. It's really a great piece and a good table setter for a lot of what's going on in New York and nationally. And now I'd like to invite the panel up so we could begin the discussion, and then I'll turn it over to John and Kathy to keep the event going. So please come on up. Before I turn it over to John and Kathy, I'd like to just introduce the panelists. And I would just maybe say a little bit about yourselves. That you're a well-known group to this crowd, but we'll go starting with Amir. Maybe we'll start with Amir. Introduce yourself and say hello.
Sure. Hi, everyone. My name is Amir Basiri. I am a senior policy advisor for health in Governor Andrew Cuomo's office, and I work closely with the Department of Health on a number of strategic initiatives around expanding access to coverage for health care, pharmaceutical policy, and Medicaid redesign.
Good afternoon. I'm Courtney Burke, the Chief Operating and Innovation Officer with the Healthcare Association in New York State. We represent different providers across the state, mostly hospitals, but also skilled nursing and in some instances home care agencies that are owned by those hospitals. Spent some time working for government, also spent 10 happy years here at the Rockefeller Institute working on health policy research.
Some would say your happiest years were here.
I'm Lev Ginsberg, Senior Director of Government Affairs at the Business Council. We are a trade organization representing about 2,300 employers in the state of New York. We represent the biggest companies in the world and some very, very small companies. I handle a lot of our issue areas, but including health and health insurance policy, which I guess is why I am sitting here today.
Good afternoon. I'm Lara Castle. I'm the coordinator of Medicaid Matters New York. Medicaid Matters is the statewide coalition representing the interests of New York's Medicaid consumers. We have over 100 organizations, consumers, individual advocates involved in our work from a wide variety of perspectives, and we all come to the table under the umbrella of Medicaid consumer advocacy.
And I'm the non-New Yorker on the panel. Hi, I'm Dan Muse. I am on the faculty at Woodrow Wilson School at Princeton University, and also the Deputy Director of State Health and Value Strategies, which is a national program of the Robert Wood Johnson Foundation. We provide technical assistance to states on a range of healthcare issues, and I have been on the ground helping 7 or 8 states at this point think through public options, Medicaid buy-ins, call it what you want. They kind of all feel the same, even though they all have different names. So I'm happy to bring a perspective of what's going on in the other 49 on these topics.
Well, great. Thank you so much, panel. I'm going to turn it over to John and Kathy now and get the discussion going.
And thanks, everybody, again, for joining. So I think you can tell from that wide variety of perspectives and experiences, we'll get some, I think, some good interaction and thoughts on this. So we want to kind of, just to get things moving, we thought we would start out with a question that we'll pose to each panelist, and maybe we'll just go in order here to make it easy. And now that we've had a little bit of discussion to kind of tee up what some of the issues are, as well as the amazing amount of coverage and activity that's going on at the state and national level, we want to ask each of you just to talk briefly about, from your perspective, what do you see as some of the key issues that you want the audience to be aware of around the expansion of public programs, be it Medicaid, be it Medicare, and also the notion of, Kathy made a good point about the sort of the incrementalism and creativity. Do we build on what we have, or do we move to some other different model? So we'll start with Amir. Maybe you could tee it up, and then we'll work right down the lane there.
Yeah, no, thanks for the question. I think one of the biggest considerations we should have is building on what we've created and preserving the success that New York has had under the ACA in creating a very competitive marketplace, which is something that most buy-in or expansion of public programs is really trying to get at, is addressing the lack of competition. In New York, we don't really have that issue. We have over 12 insurers that participate on the exchange, and most people have at least 4 options when choosing a plan. And any coverage expansion idea or proposal that we consider, I think we should build from what we've created and ensure that we continue to leverage federal resources in any way, in the best way possible.
So I'll second what Amir said. I think many people in this room might remember 10 years ago when you were part of conversations pre-ACA of how we would go about ensuring coverage for people in New York State. And it was not a easy conversation. There were lots of details that went into the analysis at the time. And you referenced at the beginning, Kathy, the minutia that you have to go through to understand what is going to be the impacts of any policy change. And we did that. We talked about things like merging the small group and individual insurance markets. Is a small group 50 people? Is it 100 people? What would the impact be? It's really important that we have that level of detailed conversation, I think, before doing something that could have potential unintended consequences. So I agree with Amir's point of the importance of building on the success that we've had rather than potentially disrupting what I think is a really good story in New York. I just, of course, from my point of view, have to make a second point, which is throughout this debate, one of the things that I don't think gets enough attention is the fact that a lot of these changes affect providers in not necessarily the best way. So we, as an organization, Haney's, supports the idea of access to universal coverage. The more people who are covered, the better their care tends to be. It's better for hospitals because they get paid. But if it's a government payer, the history in New York is that government pay hasn't tended to be so good. So the statistic we use is that Medicaid pays about 73 cents on the dollar for what the cost of care is. So you can imagine what the impact of that is on the providers and the ability for them to both meet their budget, keep their doors open, serve patients, ensure access to care, and then potentially cost shift to those who are in the commercial market. I have lots of other things that I'll just tee up. I think another important thing to focus on in this conversation, as was mentioned, what problem are we trying to solve? And there are issues that I think are equally concerning, like the affordability. So you can ensure coverage to everybody, but does that actually mean that they can afford it? And does it actually mean that they can get access to care? I think there's a lot of concerns about the workforce, the aging of the population. How are we going to support the demographics that are going to happen in the next decade? I would say innovation in some of the disruptors that are coming into the marketplace, non-traditional types of healthcare providers, and how do we adjust to that? So rather than keep going, I'll just tee up those ideas for further conversation.
Thanks. Pardon me. I also would echo what Amir and Courtney have to say about the incremental sort of progression from where we are and not going out of our way to solve problems that don't exist, and focusing on the really very small number of New Yorkers that are still without coverage. The Business Council, like Haney's, supports efforts towards universal coverage, and really thank the Rockefeller Institute for providing this forum for us to talk about real solutions that are actually achievable. The Business Council and our members are in a unique position because we tend to be the largest payers in the healthcare space. And we pay in a number of different ways, and I think that people don't always recognize that. So first of all, we're the largest property taxpayers. Obviously, we also pay significant amounts of other forms of taxes in the state. But on top of that, as providers of health insurance for our employees, we pay premiums that we've seen, of course, increase year after year based on the ever-increasing cost of health care. But what we're also doing is covering a gap that Courtney spoke about, which is when the providers, when the hospitals are being reimbursed at a significantly lower rate from the Medicaid program and from others, they turn to private insurers to make up that gap. So we end up paying more than the 100% or the $1 of that amount. So our members continue, and businesses across New York continue to get taxed, if you will, on multiple levels. So when we talk about these things, we always do have cost in mind. I hate to ever be William F. Buckley, sort of standing at the precipice of history screaming no. So we're all for innovation. But one of the things I would tee up is the availability of the allowance of being able to do new and exciting things in the healthcare space. And I think that health insurers in the state have been innovative time and time again, but tend to be stymied to a certain degree by the regulatory environment in the state. So, one of the things I think that needs to be put on the table is if we're going to open up all sorts of options, we need to look at the system as a whole and sort of look at the areas where we're being stymied in, as far as cost savings and things like that.
Thank you. And thanks to the Rockefeller Institute for providing a consumer perspective as part of this discussion. I wouldn't say there's necessarily a clean segue from the business perspective to mine. I was trying to think about doing that, but I'm not sure there is one. So I'd like to start by saying, while this forum is called Medicaid for More, and the topic of the paper is Medicaid buy-in as an approach to coverage, I'd like to make the point that this is really not distinctly a conversation about Medicaid per se. It's a much larger discussion, obviously, given the ramifications of upending a system that we have now to create more affordability and more coverage for more people, et cetera. With that said, from the Medicaid consumer perspective, I think it's really critically important to remember in this conversation that Medicaid, particularly in New York, has, there are distinct intents behind the Medicaid program. It's intended to serve low-income people and serves a tremendous purpose for people in particular with long-term and complex needs. So with that as a starting place, from my perspective, I think it's really critically important that we remember that in this conversation. The Medicaid program, again, really ought to be protected and preserved from that standpoint, given the intent of the program.
And I would say, what I heard on kind of making sure you know what you're trying to achieve is a core element. 10 days ago, I was in Hartford and kind of said the exact same thing to a group of legislators, that kind of assuming a program like a Medicaid buy-in or a public option without effectively understanding what you're trying to achieve and who you're trying to achieve it for is kind of like going to Home Depot and buying a power drill knowing you're going to make an improvement to your house, but you really don't know what that improvement is. And it turns out you needed a Sawzall and not a power drill, and you might be out of luck. And so being thoughtful about kind of what you're trying to achieve, because of the problems that you're facing on the ground, or the policy goals that are kind of expressed by elected officials, by constituents, then you can start to see what types of tools you can use from a policy perspective to achieve that. And frankly, we know that New York is already ahead of at least 48 other states because of the use of the Essential Plan and solving a significant affordability issue for a large swath of the population that seeks coverage in the individual market.
Terrific. Okay, we're going to transition to Kathy. She's going to tee up the next question. And while we're doing that, I just want to follow up on Laura's point. You made a really good point about the sort of making sure we preserve the sort of original intent of the program and its capacity. How in this debate, how do you go about, let's say, measuring or somehow putting some discipline around that so policymakers could quantify that, for lack of a better term?
That's a really great question. And one of the things that we continue to try to work on and really be much better about in our approach to policy is data. And in particular, in the area of Medicaid, there are many, many sources and sets and There's a tremendous amount of data out there. Some of it is state health data. Some of it is sort of lives with the managed care industry. But we could be doing much better at analyzing who's in the program, what services they use, what they're, even getting down to the level of what they're approved for versus what they actually use, which gets at a whole set of issues around, you might get approved for something, but good luck trying to find a provider to help you get the services you need. So I think there's a lot of work that would need to be done to expand on what we already know as it relates to the current Medicaid program. And I'm sure that there are ways to do that in a smart way.
Thanks. Well, I'm going to start out with a question for Dan, a little home cooking from my state of New Jersey. And I know, as Dan mentioned, New York has a basic health plan, and New York is in a different place than a lot of other states. But I'm hoping you can sort of educate us, the people here, the people in the audience, about what you're learning in your visits to different states, and how are states starting to approach this issue, and what kinds of things are they thinking about lately?
Yeah, so I think that kind of the one core piece to understand is that every state recognizes itself as a special little snowflake and says that I'm different than all of the other states, so bear that in mind. But each state is leveraging kind of this idea of public engagement in kind of public government engagement in the insurance market to solve specific problems. And each state is kind of recognizing the problems that it has and crafting a solution for it. So in New Mexico, the environment is such where Medicaid is a very large payer. Roughly a third of New Mexico residents are on Medicaid, and it is very popular and kind of widely adopted from a provider perspective across the state. And so when you have a situation of low competition on the marketplace, higher than national average premiums on the marketplace, and kind of a desire to affect affordability, then kind of building a system based on the chassis of Medicaid that is very popular becomes something that really took hold. And so I think what New Mexico is looking at is crafting a solution for persons that would be kind of otherwise on the individual market that maybe aren't getting subsidy, and therefore are paying very high premiums and very high out-of-pocket costs, but they would be happy with a program that was sponsored by the state Medicaid program. That there is not a stigma in that, like there might be in other places and in other states. And so kind of that is the political dynamic that's allowing the new governor there, Governor Lujan, to look at the Medicaid buy-in as a true option for solving for some continued high uninsurance rates and a lack of affordability that's driving those rates. So you see that on the ground in New Mexico as a solution. You move up to Washington, where a similar project is being undertaken. It's called a public option, even though it's literally the same thing, right? You're using your Medicaid agency to procure plans for sale to folks in the individual market. And for Washington, again, it's straight up premium affordability with a focus on crafting plans that are easy to understand. And so that consumers aren't struggling to understand kind of what prescriptions are going to be available, what providers are going to be available, what's before my deductible or after my deductible. And so a combination of standardizing plan design and having the state be a procurer of these services is driving that effort in Washington. And I should say Washington was one of those states that was facing bare counties. And they had 3 or 4 counties where they were looking at not having any carriers. And so for Washington, having that public option be at least an option was something that really drove their thinking.
I just want to ask a follow-up. Can you shed any light or give us a little color on what stakeholder reaction's been like in those two states?
Not dissimilar to what I heard as it traveled down the table to me, right?
Really?
So providers are concerned about rates because we know the commercial market pays the best and that Medicaid doesn't. And so when you're kind of splitting the difference there, exactly where the rates fall out matter a lot to providers. The kind of argument back from government tends to be, we're losing people from our individual market. And so is it better to get paid a little less than your normal rates than to have folks that are uninsured coming in, going into bankruptcy, negotiating with you individually on big bills? That's kind of a question. The business groups are saying kind of what Lev said, right? You know, what's our role here? What are we expected to pay? If more people are going into a publicly supported program, is there going to be more cross-subsidization from us, and are our rates going to go up because of it? And I think that, you know, since no state has actually implemented a public option or a Medicaid buy-in at this point, those arguments kind of are hanging out there without evidence in either direction.
Another, just if it's not too much in the weeds, just on the prescription drug issue, the discounts that the Medicaid program gets for prescription drugs, I assume would not be extended to this kind of a buy-in. So how much does that take away the comparative affordability?
Yeah, so that's a great question. I mean, prescriptions account for 15 to 20% of your overall premium spend. So there is going to be a bump in kind of how much money that is per premium dollar. If you don't have the 340B rebates and the ability to capture those dollars. That being said, I think there are a lot of states who are saying, okay, but if I'm procuring, right, if the state is the purchaser of the insurance or the purchaser of the plan design, we also buy a whole lot of prescription drugs for state employees, for corrections. Maybe we can think about our purchasing power there and craft a solution that allows us to leverage our scale.
Excellent. Okay, I should get off my soapbox here and let them turn.
I actually want to pick up on the provider rates a little bit more as well, and maybe just as we, you know, this is exactly what we wanted to kind of do, is kind of like, as we think about the details of these proposals, the details really matter because the implications on lots of parts of the delivery system kind of come into focus, and this will be debated. So Courtney, and really all the state colleagues from New York, maybe we can learn something from the experience where over time the state has incrementally expanded Medicaid successfully. It's done a fantastic job with the so-called essential plan, which has largely solved the affordability issue for people under 200% of poverty through that ACA mechanism. Very low cost sharing, very low premiums on the part of individuals. So as New York has embarked on this journey over the last many years with many, many hundreds of thousands of people now in more of a public kind of arrangement, you know, maybe Courtney, we start with you. How has this issue that we're talking about conceptually about provider rates, how has it manifested itself among your members and your business? It would be great to hear that.
Sure. Well, I mentioned earlier that Medicaid pays 73 cents on the dollar for what it costs the provider to deliver that service. But if you look at what's happened in terms of Medicaid losses for hospitals, since the ACA went into effect, the Medicaid losses for hospitals have gone up 43%. So the impact is real in terms of, yes, we're seeing people who have coverage, but you're also seeing losses because more of them are Medicaid. So I think it's just important to watch that trend and what it means from a practical standpoint for hospitals to keep their doors open, because if they can't keep their doors open and they close, then people don't have access. So that's why I mentioned earlier, it's not just about coverage, it's about access to care as well. One other thing I might mention is we've watched what the impact has been on providers and whether there's a difference depending on where you are in the state. Interestingly, Medicare, which pays a little better than Medicaid does, it tends to be providers upstate who have a lot of Medicare, but don't have a lot of volume. So upstate we've been losing population. So they're seeing fewer patients, but they're getting more Medicare dollars. Those tend to be the hospitals that are distressed financially. Downstate, it's a different story. It tends to be hospitals that have a lot of volume, and they have high Medicaid as a payer. So I think it's important to understand those hydraulics when you're looking at the impact on provider payment rates.
And just to drill down a little bit more, so what have been some of the I'll say, the business reactions on the part of some of your members, either from Courtney or Lev, in terms of how has some of these dynamics manifested itself on the business side?
Let's start.
I guess I'll just start in. It makes in terms of a negotiation. It's still, even though hospitals are nonprofit, they still have to try to make a margin, and New York is notorious for having some of the worst margins for its hospitals. But then you have to make it up somewhere else, and so that's when you tend to negotiate with the commercial plans to look for higher rates to make up for the loss.
I would, just echo that. But in addition to that, I think that there's significant concern among a number of our members, upstate employers especially, about distressed smaller hospitals, rural hospitals, and what a lot of these changes mean for those institutions even keeping their doors open. And that has a direct impact on the ability to entice businesses in general to come to those areas, and entice employees to come to those areas, especially those who aren't from there, who have perhaps higher education, higher skill. It becomes increasingly difficult. So there are all of these overlays, and granted, they're not direct, but they're indirect outcomes. But I think that they're very real.
Okay. And then one other, before I kick it back to Kathy, and one other question for Laura. So when we talk about, again, sort of the basis and original design of the public programs, as more individuals are enrolled in these programs, are there any measures that you've looked at around, we'll call it provider capacity, network adequacy, those kinds of things? Are people able to get appointments and those kinds of things? Are you able to monitor those kinds of things? And is that a concern as we think about opening these programs up even more?
Yes, it certainly is, and it depends on a variety of factors. Of course, we have a very diverse state in many ways, particularly geographically speaking. It depends on the type of provider that is needed. A lot of this we know anecdotally. That again, we could build on the data to know it more scientifically, but we hear anecdotally all the time. It's a perpetual problem to find psychiatry across the state, particularly child psychiatry. It's particularly there are pockets around the state that are experiencing home care aid shortages. We hear about that continuously over the past few years. So there are these, again, sort of depending on what the needs are and where you are and other factors as well. There are provider issues that relate to a variety of factors, and including workforce, and it is a problem that would need to be looked at.
Terrific. I'm going to turn it back to Kathy.
So this is a question for everybody or anybody. I think maybe Lev might be the first responder, but I'd love to hear what everybody thinks. The power of, or the reach of this movement and the support for sort of different kinds of approaches and, single payer and more sort of public provision of healthcare. At this point in a country that's 90% covered, it's really about, I would say, more than coverage. It's really, some would say it's primarily motivated by affordability concerns. And you can see the kind of twin trajectory of the prescription drug issue. So I guess the question I throw out to, state people, providers, employers, what are some other approaches that we might think about to try to address those affordability issues? It certainly caught my attention when Walmart reduced their employee cost share for telemedicine from $40 to $4, which was a large change. Who knows how long it will last and what the real costs are. But I'm just sort of curious from the hats that you all wear. People say employers, end up not fighting enough with hospitals for good rates. People say hospitals don't do enough to change their cost structure. States are starting to do some things around cost containment. Some states are putting together these cost containment coalitions, Massachusetts, Rhode Island, et cetera. So I'm just going to throw it out there and say, what are some ways that we can address this issue of affordability of health care?
So, I mean, that's the $64,000 question. And, for employers, I think it's across the board, because those that are self-insured are figuring it out because it's coming straight out of pocket. Those that purchase insurance are limited to that which the insurance companies are allowed to do to sort of create their plans, and therefore are also quite limited in the products that are available to them. So they're sort of left with a handful of plans, and then it really comes down to the cost sharing with their employees. And that's sort of the affordability question. So you've got someone who's making X amount of money a year, and their deductible is this high, right? So ultimately, they're only covered in as much as if they could afford that deductible. However, if we allowed for significantly more freedom in plan design, and perhaps took a few cues from different, strange places in the state, like Mayor de Blasio, for instance, who's looking at a plan for New York City, where they're much more narrow, they're much more skinny. We may be able to offer a significantly larger portion, or a significantly larger variety of plans for an employer, which would make the affordability question for someone who's enrolled much better. But I think that there's a host of things that can be done. It's definitely challenging, but right now in the state of New York, for instance, you can't really reward someone for wellness, just like you might not want to reward someone for walking down the street right now by those trees. We need to sort of change the way we think about coverage, because it's not simply what's available, what is covered. It's what you're actually going to use, and I recognize that has an implication on, or an impact on, what pools are left to be insured. But these are broad questions of affordability, and I think that we need to start opening that discussion back up. That would help us get there. The other thing, of course, is who are we talking about? And there's certainly different pools, but I think to close the universal coverage gap, I mean, there's some minor changes I think that would be needed, but within sort of the system that we have today, I think that we can achieve it. If we can focus on plan design and plan design freedom.
So your ask of the state, for example, would be more flexibility around
sure.
plan design.
Much more than we have today.
Well, Amir, why don't we kick it to you?
So it's a good point, and it's something you see in the private markets quite a bit, with more flexibility on plan design. But what one thing we pride ourselves on here in New York and in the Medicaid program is the broad range of services and coverage options that we have. And I think even in the private market, some of the regulations that DFS and the state agencies have are really meant to ensure network adequacy and access to all coverage options. I do think there are certainly areas that we could do better on, promoting things like wellness, more value-based insurance design type models that would encourage more flexibility. It's just a difficult issue to tackle statewide, given the specific needs and regions of the state, and also the different capabilities of the insurers throughout the state, and some of the things that they're seeking to do. But I definitely would agree with Lev that that is one way to get at the affordability issue, and I think value-based insurance design is a promising thing that we are interested in looking at further.
Just to add a little bit more, I would say I think about it in different buckets that we could attack to try to address the affordability issue. The first one is the easiest one. It's primary care and using technology in new ways to help deliver care. And that's already happening where you're seeing telemedicine and the option for people to use that. But the question is the regulatory environment keeping up with that so that providers can do that as well? And when I say regulatory, I also mean payment. Are they getting paid to do that? And to me, that's the easiest problem to solve. I think it's already happening. I think the more difficult one is the one that Amir mentioned, which is not just value-based insurance design, but value-based payment for services. And we're starting to do that as well. If you look at some of the things that have happened since the ACA passed, and the ACA was very good at looking at new models of care delivery, we've had some success with things like bundling care for a hip replacement. So, typically a provider would get paid before you went to get your surgery, when you got your surgery, after you got your surgery. A bundle just looks across all those services, looks at the average and says, if you can take all of these services into one payment bundle and make it cost less, you can share in the savings. So it's a real motivator for providers to figure out how best to improve care. And I do think that value-based payment is promising. But one of the biggest costs, and this is the third bucket, is long-term care. And New York has chosen to have a Medicaid program that is generous in its amount, duration, of scope of services that it provides. And that's not necessarily a bad thing. And I think that we should be proud of that. But we also could look at new ways of using technology, for example, home monitoring and things like that, allowing people to choose to stay at home longer if they can with the right supports and services. And again, we're dabbling in that, but in all these areas, it's a lot of different strategies to try to make things more affordable.
So I want to jump in on what Courtney said about payment reform and the efforts to achieve kind of better cost controls for individuals while also helping them get and stay healthy, right? And so this idea of paying for population health is one that is taking off around the country. And if we're talking about the individual market, right, and this kind of idea of a Medicaid buy-in, it represents a new opportunity for states to actually engage in population health efforts. When you look at the current marketplace enrollees, their coverage is not sticky, right? So, raise your hand if you switch your car insurance every year, right? Do you price shop every year and find out what is kind of cost less? Probably not. You know who your car insurance is, you just renew. And everyone thought that was how health insurance was going to be when the Affordable Care Act happened, and it's not. Every year, folks go back, they find what's cheaper, and they go into the plan that's cheaper. And so what that means is that there's not the same incentives for health insurers to invest in population health. Because if I invest in patient A's diabetes management so that this year I'm spending extra money so that next year I might avoid costs, but turns out that next year they've chosen a different plan, I've wasted money. And so my incentives are not there to engage in population health. But if you have a Medicaid buy-in or a public option where those investments are a requirement of the procured contract and that the payer, kind of the state is saying, you have to do those things, you have to invest in population health because we are helping to either subsidize through RAPs or through our federal investment, or because it's a policy goal, then all of a sudden you have more of a lever to engage in long-term cost containment for a population where there are not market-based incentives to invest in it right now.
What are some other things you think states can do, other leverage points states have to try to, going beyond the individual market, to try to constrain healthcare spending growth?
Yeah, so obviously with the combination of the number of lives that state governments pay for, you have Medicaid lives, you have state employee lives, you have correction lives in some cases where you've got a lot of sway in the market. So that's one. I would say the next is that the federal government, the Center for Medicare and Medicaid Innovation, CMMI, has really engaged with states in developing broader payment models. So in Maryland and Pennsylvania, we have global budgeting models for hospitals wherein hospitals are getting kind of basically a set amount of money that they know they're going to get that is indexed to certain inflation rates, and therefore a bad flu season is not one where nobody gets the flu, right? Because that's what happens in a lot of small rural hospitals. Is a bad flu season is the year that nobody shows up at the hospital. And that can actually close hospitals for just a year or two. And so if you're thinking about how do you take a set amount of money and then invest it in the health while also knowing that you're going to be able to keep your doors open, then kind of where states can engage in that and support it with Medicaid programs, support it with effective regulatory structures, you're going to see more engagement in creating a healthier population, creating a sustainable cost growth for hospitals and for the healthcare system in general.
I just wanted to add really quickly, I think I'd be committing a little bit of malpractice if I didn't mention it, although it's a conversation probably for another day. But if we're talking about controlling healthcare costs, we really should also be discussing some tort reform issues. Because at the end of the day, medical malpractice against hospitals, against doctors, of all providers, is driving up not only the costs of care because of the insurances involved and the payments, but data shows a huge amount of unnecessary testing that's going on that's driving up costs, which is basically cover yourself kind of medicine. So granted, it's only one piece of this giant puzzle, but I think that it's one that's necessary to talk about in the global sense when we talk about these issues.
Okay. Great dialogue. I just want to, I'll make a comment and then I want to tee up another set of questions. I think one of our colleagues talked about bulk purchasing on the part of states. And in California, in the governor's new budget out there, Newsom actually envisions some kind of bulk purchasing around pharmacy where they said, we've got the Medicaid program, we've got corrections, we've got the state employees, a massive, amount of enrollees, and I think they're going to actually explore something along those lines. The challenge for them is going to be if they go that model, what happens to those so-called big Medicaid statutory rebates? So I think a lot of people will be following that to see how that plays out and to see if this is a real lever. I want to kind of bring us back a little bit to more operational considerations because these proposals have some very grand ideas, and we've heard a lot about the goals of affordability and access from the panelists. And would like to ask each of you from your experiences, to the extent states want to become more active as purchasers or expand their public programs through a buy-in type arrangement, what's your assessment? What are some of the either concerns or issues you would want to raise around the ability to actually implement it? We went through the ACA. You've got a lot of colleagues up here that actually implemented that 8 or 9 years ago. So what are some of the kind of key considerations about a state being able to implement such a program?
Yeah, I'll start. It's a very interesting question. I think it really is dependent on, what the structure is of your healthcare market in your state. Here in New York, we are very much a managed care state where we allow managed care plans to do a lot of that work in driving down costs and getting better rates. To use the example of bulk purchasing for prescription drugs, we allow the plans to do that on Medicaid's behalf while leveraging the Medicaid rebates. So if we were to change to do something like what California is proposing, we would have to change the program entirely and take that out of the plan's benefit, and the state would be negotiating on behalf of everyone. So you're kind of taking the risk away from the managed care plans, and you're putting it on sort of the state's behalf in order to leverage that bulk purchasing. But in many instances, it's not the most efficient way to manage costs and structure the benefits. So it really is dependent on what the services are and what you're really trying to get at. And I think in New York, we were previously and still have been very much pushing towards managed care, pushing towards value-based payment, and a lot of that is sort of provider-to-provider negotiations to drive down costs and increase competition. So we would essentially be kind of going, not backwards, but we would be taking that function away from a lot of the entities that have held that responsibility for the past decade or so.
And can I just do a follow-up on that, because that's, I think, a really key point. So in terms of state infrastructure, the business aspects within the state to do the operations, the enrollment, the eligibility, the payment, those kinds of things, it sounds like a lot of that is, with the managed care plans now. So does that, what are the implications of the state, I guess, rebuilding, if you will, some of that?
I mean, with the state marketplace and ISO, there is a lot of those functions in-house that the state does in terms of eligibility, enrollment, subsidies, et cetera. I think, expanding that certainly has significant costs associated with it, especially if we're talking about new populations and new eligibility. So it's certainly something that has to be taken into consideration. Also, noting that it's likely to be state-only costs, not something we could leverage federal resources to do if they are non-Medicaid populations. But it is possible, but state government's not always the most nimble as compared to the private sector. So it's just something that has to be taken into account in terms of ramp up and efficiency.
I was going to just step back a few years to when New York State implemented the exchange and what it was like, as I was working for state government at that time, and it was all those operational issues that you referenced. The technology actually was one of the biggest concerns. Is the exchange, is the marketplace, is the online marketplace going to be up and running when we launch this? And as you may recall, the federal government didn't have quite as much success. It really, things set them back, but luckily in New York it worked for us. But I think a second thing that the state had to focus on was just the awareness and education for people. And we partnered at the time with a lot of consumer groups to make sure that questions could be answered. And a lot of that funding has been pulled back since the ACA started from the federal government to help educate consumers. So if there are changes again, you really need to be able to answer the questions. Otherwise, people don't necessarily know what's changed. I would say it's the same now for providers. There's big implications for them in terms of the patients who come through their door, being able to educate them about what they may or may not be eligible for. And I would say that there's larger implications for the marketplace overall. Anytime you change or tweak a program, you're potentially shifting the risk around, and you don't necessarily know what that impact is going to be most immediately. So that's where concern for all of us comes in.
Yep. Great.
So one, Amir kind of mentioned this at the outset of his comments, that you don't want to lose federal financial involvement. And so states that are looking at Medicaid buy-ins or public options are being very careful about how they structure them so as to not reduce the subsidy levels. So you could craft a Medicaid buy-in or a public option that you sell in your marketplace, and it could tank your lowest cost silver or your second lowest cost silver, which then brings down the amount of tax credit dollars coming into your state. If you do that, all of a sudden you're kind of saving money for the feds. And I am a state official at heart. I'm a recovering state official. And the worst thing ever is to not take all the money you can from the feds. So, what states are doing are looking at public options that are crafted to be kind of actuarially designed so as to not kind of lose that tax credit purchasing power that your folks have on the marketplace. So just kind of being thoughtful about all of those little rules and playing them out as you're implementing a coverage expansion or a new option is critically important.
Can we just stay with that? I think this is a really essential point. Explain, if you could, why such a buy-in could trigger the reduction in tax credits, number one. And then I guess number two, what does that portend to the private plans on the exchange?
Right.
So that's got to be a dynamic in the states you're working in. So help us understand.
Yeah, it is. So, right, so the way that Affordable Care Act calculates subsidies is it, rather than saying, kind of setting an age target and giving you a flat dollar amount, it is indexed to your income, and the premium cost of what's referred to as the benchmark plan, or the second lowest cost silver plan. So we've got bronze, silver, gold plans on the marketplace. The second lowest cost silver for your rating area is your benchmark plan. And basically the feds will give you a subsidy in the form of a tax credit based on your income so that you can afford that second lowest cost silver. And then you can take those dollars and shop with them as you please. If a public option comes in for sale in the marketplace and is a silver plan and is lower than the second cost silver, then it will drag down the premium of that benchmark plan, which then ostensibly makes insurance more affordable, and so you need less of a subsidy, right? And so you could draw that down. So then, and I think you're also referring to, John, the kind of moral hazard of placing a public plan for sale in a private market, which could have the effect in some places of having the private plan say, actually, if there's a public option here, I'm not interested in playing because I lose money on every plan I sell, it's hard to sell, I don't want to negotiate for the 3,500 residents in this county, so I'm just going to let the public option take care of that. And I think that is a concern among states that are pretty far down the path. And so I think for those states, they're thinking about how can I make this option kind of structure it so that it doesn't create that moral hazard. And one of the ways that they're doing that is to offer it off marketplace, right? So to say, if you want the subsidies, great, you've got your options for the marketplace on the, and you've got private plans there you can buy. If you are unsubsidized and paying a lot for your health insurance, then maybe you can come off of the marketplace and buy into our public option pool. So that's one. The other, so the governor of Minnesota just released his public option plan as part of his budget. And one of the, it's not just premium dollars, right? It's also, as Lev mentioned, the deductibles, right? That the out-of-pocket cost sharing that's really hitting people and saying it doesn't matter if the premium's $300 a month. If the deductible is $12,000 a year, I still can't afford that. And so it's not worth it for me to buy into the coverage. So the governor of Minnesota is suggesting that his public option in Minnesota will have an actuarial value over 90%. So much closer to kind of what we think about the old style employee plans, right? Employer-based plans, or kind of in the current parlance, what public employees are used to. So if you think about what public employees are used to as far as their insurance and benefit packages, that's that kind of over 90% actual value and having what's called a platinum plan on the marketplace.
Yeah, well, and thank you for that. I think we're going to transition to some audience Q&A, but I think this last discussion really highlights the complexity of the issues that we tried to tee up, at the beginning and also in the paper around we might want to be solving an affordability problem, or we might want to be solving a Bexar County problem, but we have to think through all of the implications to know, are we going to create a different set of problems? And your point about the tax credits and about provider participation or insurer participation, I think is very good. And then I think, Courtney, what you were talking about in terms of the shift to more public rates, for lack of a better term, what is that, implications of that on the provider community as well as the marketplace? And what does the evolution of the marketplace look like in that context? We've got, I think, about 10 minutes or so left, and we wanted to transition to some questions from the group. And again, thanks. I think this has been really terrific back and forth. I've taken another page plus of notes myself on this. So I'm just going to try to read these properly, if I can, in terms of what the questioner is really trying to get at. But assuming that the national political balance shifts in 2020, and I'm just reading this, okay, towards a progressive, setting. I'm trying to get this right. Extensive and serious. I'm really not following this particular question. So maybe I can rephrase this. So if things start moving along the lines of a more progressive, and we end up with something more akin to Medicare for all kind of proposal, which we have actually different presidential candidates who've put it out there, and one of those is up on the board now. I think what the questioner is asking is, how is that going to, what's the interplay of that with larger governmental programs, and not just even in the healthcare space, but how does that affect the overall role of the government and its ability to finance other kinds of programs?
Can I just jump in here? And I hope I'm not stealing your thunder, Laura, but I feel obligated to make the point that a lot of these bills that are being discussed or proposed don't focus a lot on the issue of long-term care and the special supports and services that a large percentage of the population receive. So my concern when I hear these debates is they're largely about people who are either covered already or maybe underinsured or uninsured, but they don't talk about the aging population, they don't talk about the disabled population, and they don't talk about the special programs and waivers that a lot of those populations receive their services through. So I'm not really answering your question at all, but I wanted to use the opportunity to make the point that it's a part of the debate that has really not been discussed yet. And my concern is that because we're not talking about it, what would be the potential impact on those populations?
Yeah, so Laura, do you want to expand on that? Because I think that is kind of a critical point where in all of these sort of very, we'll call it Medicare for all in terms of what's up there on that diagram, but how does it affect, talk a little bit more about how it affects these underlying programs, a lot of history, a lot of infrastructure, if these start to transition. And this also, I guess, gets to some of the operational issues about how you'd even manage this, right?
Yeah, absolutely. As I said at the outset, New York's Medicaid program is, of course, intended to serve low-income people, but has a tremendous focus on, as Courtney said, providing for the needs of people with long-term complex needs. For instance, there is an array of services for people with intellectual and developmental disabilities that are covered by Medicaid. And just as that one using that one population as an example, I think is important to take a really laser-focused look at how these programs are provided, how the services are provided, how they're covered, and how they would be impacted by potentially going with some other coverage option. They are, and again, I think using the population of people with intellectual and developmental disabilities as an example, there's a long history. The services are complex, and there are very distinct ways in which the services are provided and covered again. So it's an important consideration to take. And I think as far as implementation goes, and Courtney touched on this before, Dan also mentioned this, consumer information and education is really has to be at the core of what we're talking about. I think there's a point to be made that something like a third of the remaining uninsured in New York are actually eligible for coverage today. But for whatever reason, they haven't made the choice to be covered. And so there's some outreach to do there. There needs to be, of course, understanding at the consumer level about what their options are and what's available to them. And as Courtney said, and I'll mention again, there's a robust and strong system for consumer assistance in New York, and we need those type of services to continue. Assistance, advocacy, navigation, et cetera, is critically important and would need to be considered as the design of any kind of new system.
And I want to just keep, because one of the questions kind of gets to some of the details around that. So, Dan, in the states that you're working with, how much are the issues that Laura is describing and what one of our questioners is interested in, the disabled, the long-term care piece. How does that play in? While not necessarily the benefit level, but more on the infrastructure, the provider capacity, the state capacity to manage, for example?
Yeah, so, I think that that in the states that are really kind of actively seeking to leverage their Medicaid program, right? So a state like Connecticut isn't looking at its Medicaid program because it doesn't use managed care. But so the states like Washington, like New Mexico, that have strong managed care, that are kind of looking to add to their individual market offerings through something built on the strengths of a Medicaid program, are the Medicaid agencies are being incredibly active in advocating for their current populations first before they say we can take on the burden of helping out the individual markets. And so basically what's going on is you've got Medicaid agencies, when these bills are coming up, saying, this is an interesting idea and we could definitely handle it, provided we have the resources to hire the staff to manage the contracts and procurement and not take away from our current populations. And I think that that's kind of has been a core element of the buy-in proposals around the country. How a larger kind of transition away from our current market, kind of private insurance market structure, towards something kind of on this side of your slide up here, gets at that question of, are you protecting the programs that are in place for the most vulnerable, for those that need special benefits? New York is in a place where you're advocating for protecting those programs. There are a lot of other states where folks are saying our programs are awful. And folks with intellectual disabilities are not protected and don't have the services they need, and something like a Medicare for all would be better in our state because of it. And so you definitely have some state-by-state differentiators here when it comes to protecting vulnerable populations.
Okay, thank you. And our last question kind of highlights all the variation among states. So states are different, and yet we often have a one-size-fits-all approach, is the question premise. New York expanded Medicaid. It has a robust exchange. I think, Amir, you kind of touched on that in your remarks. The result is there's only 5% uninsured. But the questioner goes on to ask, well, how do we get policymakers to focus on the problems through data as opposed to the politics of the healthcare debate? So I think that's a great question to end with.
It is a good question. I think that data is a very powerful tool that can be used even when you have only 5% uninsured rate. As you saw with the recent enrollment report, we were able to increase enrollment and target outreach in areas that had higher uninsured rates than others, and that resulted in more people signing up and getting on the exchange. So, that may be one example. I think there's other things that can be done as it relates to enrollment and auto-renewal in Medicaid to reduce the churn that naturally happens when people's incomes change throughout the year. And that's, 2/3 of people that don't have coverage. So I certainly think that data can be a very powerful tool in targeting efforts and continuing to chip away at problems that we know where they are, and we just need to have a targeted approach to address them.
Yeah, please.
Well, I absolutely agree with the assessment of the importance of data in solving any problem and the importance of facts in solving any problem. But I think even if we do get to universal coverage in New York, there are still other issues that we have to focus on. And I'm not sure if any of the current proposals really focus on those issues. And so I guess I'll end up where I started off, which is the concerns about the workforce, the concerns about the overall cost, concerns about affordability of care for people, that those are still unsolved with a lot of the proposals that are on the table today.
And not to end on a negative note, but one of the most difficult aspects of my job is trying to convince those that make decisions in government to pay attention to data, to pay attention sometimes to simple arithmetic, frankly. But most of the time you're up against emotion. And it strikes me that we're in a political environment where the loudest voices and the most emotional of those tend to win over data. So I think that we're in a difficult position as far as trying to convince those that make decisions to follow the data. But, you know, I applaud any effort that you're all making. And
Okay, and
continue to do
I think you all have given us a lot of ideas for like a next paper on this, some great ideas. So we're at the time. I'm going to turn it back to Jim to wrap us up. And thank you again. Great.
Let's give a big round of applause to our panelists. Dan, I'm going to use your line that we're all recovering state officials, so I appreciate that. This is just, in Albany especially, this issue is on the agenda for this year, whether it's single payer, Medicaid for all, what do you do? So this sort of informative discussion, I think, only helps drive a good outcome. Let's give a big round of applause to John and Kathy for their great paper and presentation. At the new Rockefeller Institute, we get you out on time, so thank you all very much for coming. Please be safe out there in the wind, and we'll see you next time. Thank you very much.